Good afternoon, everyone, and welcome to SAMHSA's Gain Center's webinar, SAMHSA's 8 Guiding Principles for Behavioral Health and Criminal Justice. I am Melissa Neal. I am a Senior Research Associate at Policy Research Associates and also the lead for communications for SAMHSA's Gain Center. And I'll just be providing a few housekeeping remarks. First, the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. And just a couple of reminders. First of all, throughout the presentations, we welcome you to submit your questions. To the right side of your screen, you will see a Q&A pod, and there you can enter questions at any time. We will be holding off answering questions until the end of all of our presentations. And so towards the end of the webinar, we will work through the questions and have a dialogue with our presenters. We also have a couple of polls open and really appreciate your participation. This will help us have a better gauge and understanding of who is participating and what the different perspectives are of of people participating in this webinar. And finally, this webinar is being recorded. Just a quick look at our agenda. We will have some opening remarks from SAMHSA, and then we'll transition into 3 presentations. The first, which will look over all of the principles that were created. And then we will have 2 presentations that do a deeper dive into 2 of the principles. And as we've started to work with jurisdictions across the country on these principles, these 2, Principles 5 and Principle 7, have really emerged as areas of interest and further TA. So we decided to do 2 presentations that specifically focus on those 2 principles. Now, this publication is live on the SAMHSA Store. However, if you haven't had a chance to download it, now is a chance. And this may help you as you go through the webinar with us and as we go through each principle. Having this publication on hand might be helpful. So you should see a box popping up where you will be able to select and download the file. All right, next slide, please. And so now we're going to turn things over to Lark Wong, who is the Director of the Office of Behavioral Health Equity with the Substance Abuse and Mental Health Services Administration. Lark?
Thank you, Melissa. On behalf of SAMHSA, I'd like to welcome all of you to this webinar. As Melissa mentioned, I'm Dr. Lark Wong, and I coordinate the Behavioral Health and Criminal Justice portfolio of work at SAMHSA. So wherever you may be across the country, we want to thank you for joining us. We're pleased with the interest in this topic, which is reflected in over 1,000 registrations for the webinar. So to begin with, why are we convening this webinar? Well, we know the disproportionate number of individuals with mental and substance use disorders who enter the criminal justice system is a key concern and priority of our agency. Every year, approximately 2 million individuals with these disorders cycle in and out of local jails. We know that a brief incarceration results in disruptions to treatment, housing, health care, employment, and severely impacts the families and the children of those incarcerated. Once in the criminal justice system, we know that individuals with mental and substance use disorders stay in jails longer and have an increased risk for self-harm. For individuals already receiving medications and treatment in the community, these services may be interrupted during incarceration, creating lapses in treatment and difficulties in resuming treatment upon release and reentry to the community. And in the midst of the opioid crisis we now face, individuals with opioid use disorders are at a significant risk of death by overdose in the first 2 weeks after reentering the community. So it's vital that we pay attention to these issues. Now, more than ever, we need to know what works for people with substance use, and mental disorders that are involved with the justice system. We know that collaborations between behavioral health providers and criminal justice professionals are critical if we want to make sure people get the treatment they need and not go to jail. We know that behavioral health providers and law enforcement working together can divert people with mental illness and substance use disorders into treatment before they even touch the criminal justice system. Sheriffs, jail administrators can work with behavioral health providers to ensure that screening for these disorders is done every single time someone is booked into jail. And in collaboration with probation, behavioral health providers can support individuals in staying in treatment in their communities and leading productive lives. SAMHSA just released this key guidance document, which is the focus of this webinar. The document was developed with a consensus process from an experts panel representing both behavioral health and criminal justice practitioners, researchers, policymakers, and people with lived experience. It's based on the best research available, and we anticipate that it will be an important tool for people working at the nexus of criminal justice and behavioral health. We are pleased to have these presenters today to speak to this document, in particular Dr. Jenni Simpson, who was the main author of the document, is with us today to present on the principles. Again, we also want to thank PRA and the Gain Center for hosting this webinar, and thank all of you for the work that you do in the community and across the country. So I want to turn it back now to Melissa to introduce our presenters. Melissa?
Thank you, Lark. All right, so we have 4 presenters with us today, and first we're starting with Dr. Jenni Simpson, and she is a Senior Drug Policy Advisor at the Bureau of Justice Assistance, and in this role she works on policy initiatives and training and technical assistance for the Comprehensive Opioid Abuse Program. And prior to this, Dr. Simpson was a Senior Staff Lead for Criminal Justice at the Substance Use and Mental Health Services Administration, and as Lark just mentioned, she was intimately involved in the creation of the principles and the development of this document. She is a specialist in law enforcement diversion and has provided training and technical assistance and conducted research on behavioral health and law enforcement collaborations. Next slide. Judge Owens is a program manager with Arizona Complete Health, and he's working with the Targeted Investment, and currently is working with 3 justice clinics and utilizing integrated care in Casa Grande, Tucson, and Yuma, Arizona. And he has experience working on justice and treatment leadership initiatives throughout Arizona, and he has served over 21 years in the court system, and also has experience working in both adult and juvenile probation settings. Next slide. Cara Byrne is a Chief Clinical Administrator at Community Health Associates in Yuma, Arizona. She was formerly a Clinical Director for Children's Services at Community Health Associates. She's a licensed clinical social worker in Florida and Arizona and has over 16 years of experience. She also has her bachelor's and master's degree in social work from Florida State University. And Melissa Ziss is a mental health jail liaison for Mecklenburg County, North Carolina, and she's served in a number of positions with Mecklenburg County Area Mental Health and MecLink, including roles such as State Hospital Liaison, Housing Coordinator, and providing utilization review. She's trained and certified as a law enforcement instructor in the state of North Carolina, and has served in the past as a release coordinator with the Mecklenburg County Sheriff's Office in the Work Release and Restitution Center. She has over 18 years of mental health experience, including work with community mental health systems, inpatient psychiatric units, criminal justice systems, and with homelessness services. She's a licensed psychological associate and a master's level clinical psychologist. So without further ado, we will turn it over to Jenni Simpson to introduce us to the principles.
Great. Thanks so much, Melissa. I wanted to start first with a thank you to the Gain Center for holding this webinar. And I also want to thank all the expert practitioners, researchers, professional associations, federal colleagues, persons with lived experiences who contributed to the principles and reached consensus on these principles. I also want to recognize the federal colleagues from Health Services and Resources Administration, the National Institute of Mental Health, National Institute on Drug Abuse, the Bureau of Justice Assistance, and the National Institute of Corrections, who gave the support of their agencies to the development of these principles. I will first give us a bit of a background on how we developed the principles before I go into the actual principles. So first of all, why did we start with principles? We defined those principles as a framework for actions, behaviors, and decision-making, and they communicate core values. And this, when we thought about our criminal justice work, was what we wanted to put out to the field. And so those core values are found throughout the document, but I want to make a few explicit. First is that justice-involved individuals are part of the community that we serve in community-based behavioral health. Regardless of their involvement with the criminal justice system, all individuals who come to you for treatment and services need your support in accessing treatment and recovery and support services. Second is that providers are critical partners in ensuring the health and wellness of justice-involved individuals. Behavioral health providers are essential to sustaining someone's tenure in the community and reducing their likelihood of further justice involvement. And finally, partnerships between behavioral health providers and criminal justice practitioners should be best practice. Just as providers have traditionally partnered with other service providers, criminal justice practitioners are your partners as well. So when we started to conceptualize the principles, we started with the question of what can we do to reduce the number of individuals involved with or at risk of involvement with the criminal justice system. We knew that number that Dr. Wong mentioned, 2 million individuals in jails, the dial hasn't moved on that number. So we thought, what more can be done? And in thinking about this, we realized that historically there was a focus on criminal justice professionals and how we've approached this intersection of criminal justice and behavioral health. So from whether it be from the federal government or advocacy organizations, a lot of the materials and resources focused on training and tools for criminal justice professionals. But we recognize that behavioral health providers are just as important in reducing that likelihood of involvement with the criminal justice system. And so we found that there was a gap in information and resources and tools for behavioral health providers in working with justice-involved individuals. So we wanted to turn the resources and that kind of training and technical assistance upside down in this space and say, well, let's focus on providers and let's make sure they have the tools that they need to work with individuals who have justice involvement. So everyone who was part of the development of these principles worked with justice-involved individuals at some point in their career and were committed to ensuring better health care and outcomes for this population. I was fortunate when I was at SAMHSA to work with some fantastic colleagues, specifically John Berg and Dave Morissette. Many of you may know both of them, who were integral to developing these principles. So from the accumulated experience we all had, we knew that we knew the challenges and we lived them. But we also spoke to other providers and then with criminal justice professionals, researchers, and experts, and we found a few common key challenges, and some of these may resonate with those of you on this webinar. First was that partnerships were hard to establish with law enforcement, pretrial services, courts, community corrections, but we recognized that so many times they were necessary for shared and new clients. We were serving the same population. Then there was also the challenge of knowing the criminal justice system and the concepts, so that who, what, when, where, why, and how. Criminal justice system is a large system, and it can be confusing. So that was really a challenge. And finally, understanding what are effective and responsive treatment, recovery, and support services for justice-involved individuals. These are different in some circumstances than individuals who are not justice involved, Specifically, there's the part of addressing criminogenic risk and need factors, and this is a necessary part of effective treatment. So we understood that these were challenges that were hard for providers to overcome, but we knew that with some resources, with some guiding principles, we could hopefully help you get there. So for many of you, I'm sure on this webinar, you've worked with individuals who are justice involved, and so you know that there's an added complexity in working with the criminal justice system. There's also the additional skills that you need for addressing criminal justice involvement, from where someone may be in the criminal justice system and how to connect them once they're in the community, if they're returning from jail. These are all things that need that kind of additional skills and knowledge. And finally, there's the role of stigma, and I point to research that was done by Bandera and colleagues and published in Psychiatric Services in 2018. The article, Mental Health Providers' Attitudes About Criminal Justice-Involved Clients with Serious Mental Illness, surveyed 672 Maryland Psychiatric Rehabilitation Program providers, and they found that providers reported lower regard for criminal justice-involved clients than clients without criminal justice involvement, and that providers were less likely to report having a great deal of respect for clients with justice involvement versus those without criminal justice involvement. This is a population that has complex needs, and so there is still stigma attached with working with this population, and we wanted to address that in the principles as well. After drafting an initial version of the principles, we held a technical experts panel in August of 2017. We brought together national experts, community behavioral health providers, criminal justice professionals, professional associations, federal representatives, and individuals with lived experience. After that expert panel, we took the feedback, we incorporated it, and sent out a new draft for peer review by experts in the field across psychiatry, psychology, social work, criminal justice, criminology, and medicine. We also sent it back to the expert panel participants for them to get to consensus on. Finally, we also posted the document to our website in May of 2018 for public comment. After receiving all of that feedback, we put together the principles that you now have. So I will start in with those and provide you a brief overview of each of the 8 principles. So the first principle is about knowledge. Understanding the criminal justice system can help with continuous and coordinated care when an individual exits, and if it happens, returns to jail. Understanding the criminal justice system helps providers know where in the criminal justice system and with what personnel their client is and how they need support. So, for example, if a provider knows their client is in jail, they may be able to facilitate a coordinated release with jail personnel. It's also understanding and having this knowledge about the system provides opportunities to divert clients into treatment and services and advocate for these opportunities as well. These could be mental health courts or drug treatment courts. And when under probation or parole, providers can facilitate coordinated care and adherence to supervision requirements. It's that partnership with a criminal justice professional that really helps an individual adhere to both a supervision plan and try to reach the goals of their treatment plan. Second principle is focus on collaboration. We know that collaboration is essential for ensuring continuity of care and care coordination during transitions to and from incarceration, and then sustaining treatment in correctional settings and the community. Partnerships that facilitate reentry are especially important. This is a critical period, particularly for individuals with substance use disorders. As Dr. Wong mentioned, their risk of overdose death increases 12-fold in the first 2 weeks post-incarceration. As many communities struggle with the opioid epidemic, these partnerships can help save lives. So partnering can include creating the opportunities and mechanisms needed to allow coordination, communication, and collaboration for the benefit of the individual, the families, and communities. It also can mean information sharing when appropriate, clarifying roles and responsibilities, ensuring treatment and supervision efforts are complementary, and working with the client, the shared client, to identify and meet both treatment and supervision goals. Now, the next principles, principles 3 through 6, they focus on providing optimal health services. So in Principle 3, we're talking about evidence-based programs and practices. Now, these should be used for all individuals, but for justice-involved populations, there are specific adaptations. So these adaptations may include practices that address criminal thinking through cognitive skills training focused on judgment. You can also focus on motivation, problem solving, skill building that improves cognitive, social, emotional, and coping skills. And you can assist in building pro-social supports and activities. Integrated treatment for co-occurring substance use disorders, and this includes medication-assisted treatment for opioid use disorders, is incredibly important. In the principles document, we provide a list of evidence-based and promising mental and substance use treatments for justice-involved individuals. There are resources from SAMHSA, the National Institute on Drug Abuse, the National Institute of Corrections, and other federal agencies that can help you understand and implement these programs and practices. And if you have not already, I would encourage you to read the National Institute on Drug Abuse's Principles of Drug Abuse Treatment for Criminal Justice Populations, which will also provide you with resources particularly around substance use disorders. Next principle is around risk-need responsivity. So many behavioral health providers may not have encountered the important concept of criminogenic risk in their training and career. And this is important as research indicates that behavioral health treatment alone does not reduce recidivism or the risk of reincarceration or the likelihood that someone will reoffend. And conversely, interventions that only address criminogenic risk and need factors do not improve behavioral health outcomes. So just to orient those that may not be familiar with risk-need responsivity, criminogenic risk is the probability of criminal recidivism. It does not mean the risk of violence. The language may be unfamiliar to providers, but just not to be sure it's not confused with risk of violence, it's a risk of recidivism. Criminogenic needs are risk factors for criminal recidivism that are potentially changeable or treatable, and needs that research has demonstrated increase an individual's likelihood to reoffend. So these can include a central 8 of risk and needs. These are history of antisocial behavior, antisocial personality pattern, antisocial cognition, antisocial associates, family marital problems, work-school problems, lack of leisure and recreational pursuits, and substance abuse. So in order to reduce the likelihood of reincarceration, providers should expand interventions to target those that include criminogenic risk factors. The program may also address impulse control, interpersonal relationships, pro-social engagement and activities, vocational and educational supports, and substance use treatments. So I say there's a large body of research on criminogenic risk and needs, and the principles offer you a starting place for understanding these important pieces in a comprehensive treatment plan. I'd also say that the SAMHSA Game Center has released a great primer on risk, need, and responsivity that can be found online, and I'd encourage you to take a look at that. Fifth principle is about integrated physical and behavioral health care. We know that formerly incarcerated individuals are at an increased risk for serious and complex chronic health conditions and may require coordinated care with other healthcare professionals. We also know that rates of infectious and non-communicable chronic diseases are high in incarcerated populations and those under supervision, and incarceration may exacerbate existing health conditions. Some of these health conditions may include HIV, hepatitis C, tuberculosis, diabetes, liver disease, and hypertension. So testing for infectious and non-communicable diseases and coordinating medical services are part of an effective treatment plan. The sixth principle is about trauma-informed services and workplaces. Research tells us that justice-involved populations have high rates of exposure to traumatic events, and while incarcerated individuals may experience trauma specific to the jail or prison setting, including sexual and physical violence, intimidation, confinement, isolation, and coercion. And prior trauma may be compounded by experience of trauma when incarcerated. So for the safety of both clients and providers, creating and promoting a trauma-informed approach to services and the workplace promotes safety and trust and can minimize risky situations in offices in the field. And again, I would refer you to SAMHSA's work on trauma. We have a wealth of work and resources that if you're interested in learning more about how to work with individuals who have experienced trauma or create a trauma-informed workplace, I'd encourage you to look at those. Finally, Principle 7 focuses on the importance of case managers. Individuals involved with the criminal justice system or reentering communities from jails and prisons face unique obstacles in finding housing, employment, and coordinating health and behavioral health care. Case managers are critical and play such a role in connecting individuals to services and addressing social factors that can lead to a reduced quality of life, poor health, and recidivism. This includes lack of housing, employment, social supports, and untreated substance use disorders. So we know that what everyone needs is a house, meaningful work, or vocational educational activities and social connection to achieve recovery. Without those, recovery is harder, and case managers play such an essential role in helping someone get to recovery. And finally, the 8th principle addresses disparities that affect people with justice involvement. So we know that different population groups, including those based on race, ethnicity, gender, sexual orientation, gender identity, and economic status, have disparate access to high-quality behavioral health care treatment. They also experience disproportionate representation in the criminal justice system. It's important to understand the structural biases that lead to inequality and prevent their further perpetration. One simple step in reducing disparities is to welcome opportunities to serve these individuals. And so, as I started with at the beginning, justice-involved individuals are part of communities that behavioral health care providers serve. So these 8 principles provide a starting place for welcoming and furthering your treatment services for individuals that are justice involved. Thank you so much.
As far as Principle 5, Integrated Physical and Behavioral Health Care as part of Comprehensive Treatment Plan, my name is George Owens. I'm a Program Manager with Arizona Complete Health, and Cara Byrne's here with me as a Chief Clinical Administrator. So as far as the Integrated Physical and Behavioral Health Care being a comprehensive part, we've been working on, as a team, about 2 years looking at integrating a clinic, and it is called the North End Community Connection. So we worked 2 years on developing this with a number of stakeholders and through our local Medicaid program. So we work with a population of people that many times only saw a doctor if they were in the jail, they were in an emergency department, or at a crisis center. This is a population that traditionally does not understand preventive. As far as the North End Community Connection, it's truly a full collaborative of stakeholders from the very inception, from our Yuma County Adult Probation Department and their chief and the Deputy Director Mike Burt, or the Board of Supervisors. We've had everybody involved in this from the very inception, and it's been very important as far as a partnership. As far as primary partners, this continues to grow. Recently, we added Arizona at Work, which is a employment piece to it to improve jobs from like that $12 an hour job to that $20 or $30 an hour career. We promote a culture of we and us, and everybody that comes has an equal seat at the table. So basically what we've done is we've widened the circle of involvement, we've connected people and ideas, and we embrace team decisions. The naming of the clinic was designed to be stigma-free, display collaborative ownership, and to connect to the community. Our layout is unique as to probation's on the west side of the clinic, so the main probation entrance where people would come in would be on the west side. The clinic's actually on the east side, so 2 completely separate entrances, so they look like 2 completely different buildings. The clinic entrance is shared with probation as far as the administration point, but probation, to promote recovery language and stigma, made sure that there was no probation language down in that part of the building. It's actually just listed as APO. They wanted the families to feel welcome. We opened in June of 2018 and have served over 500 people. So we began this process in about 2016, and about 2018 is when we were able to open. And Cara will go over some of the services.
Okay. Hello, like George was saying, we have developed really clear signage using recovery language. We just wanted everything about the facility to be very user-friendly. And also going into this, we knew that even if we developed a great product, if the customer service isn't where it needs to be, we wouldn't be able to effectively engage. So all of our staff, from the providers to the front desk, are trained in customer service, and they're also trained in trauma-informed care. We're also just really always reinforcing with our staff how we treat people at this clinic really matters. And with that, I feel like we've developed a lobby and an entire facility that's very warm and very welcoming. As far as our specific services, we have financial screeners that assist with financial eligibility. We have medical assistants to do labs and vitals and do the handoff to the providers. We have a live family nurse practitioner with 2 state-of-the-art exam rooms. We have telepsychiatric services. Yuma is an underserved, under-resourced community, so and it can be very difficult to recruit live psychiatric providers. So we found that a telepsych services really works well for us, and we're able to maximize our resources well with that. Under the same roof, we have behavioral health case managers, behavioral health system navigators, on-site co-located peer support services. They actually lease space. They have their own signage, so they're right there with us in the building. We have Genoa, so it's an on-site pharmaceutical services, and we offer medication-assisted treatment. Our main goal was to really create a one-stop shop. We didn't want clients to have to drive around, increasing any frustration during the community reentry process. Jail and prison releases are our ideal population that we're targeting. We're in the process of developing marketing materials, but for now what we do is we do live visits or we use video chats to the jail for release planning. We know good release planning is critical to success. While potential clients are still detained, we go ahead and schedule an intake appointments. We also work to address and anticipate any social determinants of health that we may need to meet. Most commonly, we make sure that transportation's in place, whether it's a peer support or our agency being available to pick them up to take them immediately to the clinic, and housing. If housing is going to be a need, we want to go ahead and anticipate it and get to work on it so that we're not just starting the day of that release. Medication is a really important question that we ask too at this time. When they leave the Yuma County Jail, if they were on medications, they do not leave with any. So we work really hard to get the medication list, the discharge paperwork, so we can get them into our provider for a full evaluation, or at least get them in so that we can bridge the medication until they can get in for a full evaluation. We also enroll and went into the clinic on community supervision. We're really targeting the moderate high to high risk. Due to the close proximity of the clinic being right directly downstairs from the adult probation office, officers typically meet with their clients and then walk them right downstairs for an intake or to schedule an appointment or a follow-up appointment. If there are any psychiatric or medical concerns at this time, they can also walk them down to schedule an appointment, or depending on the severity, we can get them in on standby status. This truly is a huge shift from previous service delivery model, as prior to this we had a very high no-show rate and information sharing was very fragmented. At the time of the intake, we also receive risk needs assessment, so we know their risk score. We also get their face sheet, so we can understand, and we take those documents so that we can understand what the top criminogenic needs are so that we can address them in treatment planning. And this also helps a great deal when the client self-report seems to have missing or conflicted information. Cross-training has had a huge impact on the culture that we have created. Like George says, it's very we and us. We've had probation trained in treatment. We have treatment trained in probation. We've cross-trained on a variety of different topics, including risk and needs tools, so that we understand when we receive copies of each other's tools, we actually know what it means and what we're looking at. We've trained in risk, needs, and responsivity, dosage, trauma, physical health, and just an overview of the roles of the probation officer and the roles of the clinicians in the clinic, just to really help each other understand what we can and can't do and what our roles are. In the past, we had really great clinicians, but they didn't necessarily fully understand the best way to engage a justice-involved person, and they lacked knowledge and criminogenic needs. And now we've been able to really incorporate those things and speak the same language. Another thing we have found to have a lot of value in is the team concept that we created. Prior to the clinic opening, for example, we would have a probation officer that, hypothetically had 20 people enrolled in treatment, but those 20 people they had could be spread amongst 3 or 4 different case managers, which often led to frustrations in communications and breakdowns and sometimes people falling through the cracks. And what we did to combat that is we created teams. So we have specific healthcare coordinators, case managers assigned to specific probation units. So that officer really knows who his single point of contact is and can go directly to that person, and it's resulted in much smoother coordination and also drastically improved attendance for all members of the treatment team. Better communication, and really that one-stop shop. Everyone's in the same building, peer support, case manager, probation officer, so it's just led to much better collaboration amongst the treatment team.
Thanks, Cara. The basic concept of the referral process is we want to begin release planning as soon as possible. With the prison system, we have data available as to upcoming releases, risk level assignments or assessments, and the ability to video chat within the organization so the team can begin release planning with the person being released. As to probation, we work as soon as a case becomes probation eligible, which is generally in a plea agreement. We have developed a process that probation submits a referral to the clinic so the release planning can begin. We're able to video chat within the jail, which is a time saver, allows the team to actually clarify questions with someone that may be detained and not be in agreement. We also work closely with the jail to prioritize releases based upon needs. So if someone's actually going to a placement that might be out of town, this would expedite their release. Connection. This is a key concept and belief within our teams. We want to connect with the individual before they reconnect with the past, people, places, and things. We want that person to experience hope. One of the key ways we're doing this is utilizing forensic peer support. We actually have 2 agencies within the clinic that will help support the member. So that member goes in for the first day and they're doing intake appointments. If there's any downtime, we keep that member moving through. So this isn't, you go for step 1, step 2, step 3. We work this in a way that we just keep it fluid and keep it as real as possible so that person isn't just sitting around. The intake day actually could be a long day, so actually the forensic peer support people even bring in a lunch for that particular, one of the agencies actually has a kitchen. They actually bring a lunch in for the individual to make it a lot nicer for them. Ultimately, we want the person to have a connection with someone that has successfully navigated to a better life. The timelines are directly related to the connection piece. We knew that we had to connect our timelines to hit all those opportunities. So it's really important that you have to change your timelines based upon the opportunities that are in front of you. So we pre-release plan and try to create buy-in prior to release. We have same-day appointments and 24-hour intakes, assessments once they get out, and that's something we're still working towards because we're onboarding a lot of people into the system. We want them to connect to peer support upon release, if not earlier. We want services to begin within 7 days, and we want to have an ART meeting within 10 days, and that's an adult recovery team meeting, and that's basically a time to meet with the person, going through it, going, what have we done well, what have we not done well, what are we missing, and that's the time that we can refine the integrated care plan at the meeting, and then we, from there, have ongoing 30-day meetings to make sure that we're basically getting better, that we're doing that continual incremental improvement about what's going on and how to do the right thing by that particular individual. The integrated care plan, as I was talking about, we develop it at the beginning, we refine through the release process and the ART meetings, and we have that completed initially within 30 days. It's whole person care, physical health, behavioral health, and we address criminogenic needs within the care plan. As you see, we also are looking at dosage through what LaTessa has provided nationally, and Cara will go over some of our preliminary data.
I'm going to go over a couple of slides on some data. We opened our clinic in June 2018, so we haven't been open quite a year yet, but we are now in the position in the last couple of months to capture a couple of data points so we can start to see our effectiveness and how we're doing with our members. So this is just a member count. We have 521 members total that we've enrolled in the clinic, and 275 of them are integrated members receiving both their behavioral health and their physical health under our roof. This is an exciting preliminary data point for us. We know that rapid engagement is critical to success. So we are really pleased to see that the majority of our members are receiving their first behavioral health service and medical service within the first between 1 and 7 days from admission. So we're really excited about this. The behavioral health service, it can be anything from a therapy appointment, group treatment, peer support, a treatment team meeting, and then the medical appointment is going to be labs, a routine visit, or a wellness exam. This is a total percentage of members that are integrated. Out of our 275 integrated members, 103 have received a wellness visit, so that puts us at about 37%. We are always looking at strategies to make this number higher, but we are really pleased with this preliminary data. This population has a history of using emergency rooms and utilizing crisis services, so we're really teaching them the value of preventative care. We have developed a couple of strategies to increase this number. First and foremost, our provider participates in all of our cross-training experiences as well as trauma-informed care. We also highly utilize our peer supports as their credibility tends to carry more influence. Teaching our clients to keep appointments is something that we're always working on as well. If they no-show for a scheduled appointment, the first thing we do typically is contact the probation officer, and then they'll issue a directive for the client to show up within 24 to 72 hours on a standby status. Okay. And this is just an average going back to October of our show rates. We are also really encouraged and excited about this data point, as traditionally our show rates for our intakes and our medical show rate was very, very low with this population. I think we've maintained in 60–70%, which is a lot higher than we've seen in the past. We've recently, February, March, gone down a little bit, but that's also due to the fact that we're doing a lot more release planning and scheduling intake and medical dates prior to the individuals getting released from jails. So what's happening is often at that hearing, they're not necessarily getting released as planned, so that's impacting our show rate, but we definitely still want to make sure we're getting in early and scheduling these medical and intake appointments as early as possible. Okay, I'm going to talk a little bit about our HighRisk Registry. The goal of the HighRisk Registry is to identify and monitor the highest needs and highest risk population, and the intent is to truly reduce physical health and mental health hospitalizations. We've identified 3 criteria that we use to identify who's going to be on the HighRisk Registry. We use our DLA-20, which is our needs assessment tool, the OAS, which is the offender screening tool, and the specific physical health diagnosis that we have determined to be most common and make the eligibility for the HighRisk Registry is diabetes, hypertension, and sexually transmitted diseases. So if the client scores a 3, 4, and 5 on the DLA, a moderate, high, or high risk to reoffend on the OAS, and has one of those physical health diagnoses, they are going to be placed onto our HighRisk Registry, and they are flagged in our electronic health record. Currently, the clients on the HighRisk Registry are monitored and staffed by a new full-time position that we call the HighRisk Registry Care Manager, and the HighRisk Registry Care Manager is currently a family nurse practitioner. The HighRisk Registry Care Manager ensures proper interventions are identified, the referrals to specialty providers are made. We also ensure that records are collected if they have an ED visit, a hospitalization, or a visit to a specialty provider. Our HighRisk Registry Care Manager just makes sure that we are obtaining those records and just really ensures overall effective and efficient case management. This is a relatively new concept for us, something we've done just for the past couple of months, so it's really kind of grown and evolved naturally. It seems like every time, we staff a case, we sort of come up with new and better ways to improve the HighRisk Registry, and this truly is a culture change. Adding risk level to our HighRisk or to our electronic health record really positions our frontline staff to look at these cases through a different lens. Prior to the HighRisk Registry and the clinic opening, we would essentially work with clients, sometimes not even knowing what their risk levels were or what their criminogenic needs were. So understanding justice, criminogenic needs, and incorporating those into treatment planning has been one of the biggest shifts from our previous service delivery model. It's really all partners speaking the same language.
Thanks, Cara. So ultimately our summary is we follow a team concept, and it's not just the case manager and the probation parole officer, but it's even our peer supports work within the teams, or our medical works within the teams. We have a we and us culture. The team can solve their own problems. We encourage it. We have debriefings to talk to our teams and see what's working good. And leadership is basically fully supportive of this. We're wanting our teams to be problem solvers. We understand that expedited service delivery is important because these people are returning back to the community, and we need to connect with them before they connect to old habits. And in order to have that, we need to have simplified communication channels, and that's what we do with the teams. We're person-centered and we're whole health. Thank you.
Okay, my name's Melissa Ziss, so let me go ahead and move forward on Principle 7, which is case management for justice-involved individuals. So case management for justice-involved individuals really incorporates not only treatment, social services, and social supports that address both prior and current involvement with the criminal justice system in the hopes that we will reduce the likelihood of recidivism. Individuals who are currently in the criminal justice system or are reentering communities from jails and prisons often face unique obstacles in finding housing, employment, coordinating health and behavioral health care. Many of these individuals, they're in and out of services multiple times. They're resistant to participating in treatment at times, have significant trust issues, or they simply have too many barriers to overcome to attain services that they want and that they need. So what makes them unique? I could probably talk all day on that, but I only have a few minutes. But what makes them unique is that, if you look at income, everyone has to have some type of income, whether that's through employment or through SSI or SSDI, to be supported in a community. So if they're able to work full-time, part-time, they face issues with filling out applications. They have criminal records that may exclude them from certain jobs. They often have additional requirements by the court system too, which is the principle 1 we talked about, having that terminology and understanding what their requirements are if they're on your caseload and being involved with their probation officer. Sometimes they have a lack of training, education, or any support at all. A lot of times they burn bridges with any kind of family or past employers. And then they often have addiction, mental health issues, and physical health issues. Let's talk a little bit about the SSI and SSDI. It's a little bit more in my wheelhouse since I work with mostly people who are not able to work full-time. And they struggle a lot, particularly because being involved in the criminal justice system often will interrupt their income and their health insurance. So many seriously mentally ill individuals, they struggle with getting their benefits reinstated when they leave jail, as well as when they leave the prison system. And a lot of the local hospitals are often doing quick discharges with them into the community because they lack the health insurance, which is often connected to their SSI or SSDI. So if you have SSI and you go into any kind of custody, you have about a year before they will terminate your SSI. And a lot of individuals who have trouble reading and writing or have trouble navigating the system have difficulty reapplying for SSI. Now, if they have SSDI, which means that they've paid into the system enough and have worked enough to have the disability, that is suspended even while they're in prison, but when they are released, they need to take paperwork from the prison down, usually to the Social Security office to have it reinstated. And I bring this up because I was in the mental health and community mental health for many, many, many years and didn't really quite understand this until I got involved with criminal justice. However, I had one gentleman who, left prison in the 80s, never went down to Social Security because his parents were deceased. And when we were able to finally reconnect with him and get a SOAR application for him, which I'm going to talk about in a minute, he ended up getting 30 years of back pay because all he needed to do was take that piece of paper from the prison to Social Security and activate his benefits. But he didn't know how to do that. So what is SOAR? I'm going to be really quick with this. It's one of my favorite things. SSI and SSDI, Outreach, Access, and Recovery. Basically, it's a fast-track disability application for people who are homeless or who are at risk of homelessness. It's a model for assisting individuals to apply for Social Security. Typically, it's anywhere from 60 to 90 days. It averages different across each state. Every state should have some type of SOAR program to connect to, and it started in about 2005. But my biggest thing and biggest plug for SOAR is that it's such a great way to help these individuals avoid that disruption of their benefits. Because as you know, not only is their income disrupted when they get out of custody, but then again, their Medicaid is usually attached to that if they have a disability, if they're a disabled adult. And so they no longer have health insurance either. Hospitals tend to not want to keep them very long to help them get reconnected with those benefits because it's expensive. And of course, there's nobody to pay for that. I mean, I hate to say that, but it's true. So helping them get those benefits is huge. Some people can't get food stamps, at least here in North Carolina where I am, if they have certain felonies, drug felonies in particular. Women and infants, I've had this happen a couple of times with women who've given birth while in custody, and getting their WICs as they have to give custody to someone else. And so when they're released, being able to perfectly line up their release with being able to get those benefits for the child when they regain custody is also a challenge. Veterans benefits, there's a stigma there as well with the veterans, believe it or not, in terms of helping them if they're criminal justice involved. There are expungement clinics that have been put out to help people to get their record cleaned up if they need that. And oftentimes getting providers involved to help with these types of benefits can make everybody happy and help their client move along. So let's talk a little bit about housing, which is a hot topic everywhere. What makes criminally justice-involved individuals more unique on your caseload is that they often will struggle to find affordable housing. Here in a large city, we struggle with affordable housing as it is. So landlords often have their choice of individuals who have vouchers. If someone has a criminal record, that's just one more mark against them. Working with your landlord associations, finding boarding homes, and looking for these other places to help your individual get involved and get an opportunity to even try housing is huge. In building these networks, again, it's this collaboration we talked about in Principle 2. It's so important to have more than just one individual, one professional involved in trying to solve or help this, your individual with their issues, because they often have many, many, many issues that go across multiple domains. So often there's the shelter, there's transitional housing. We have a coordinated entry here, and I think it's fantastic. It's a one-stop shop in terms of all of the housing programs that are available. Sometimes there's specialized housing. We have some boarding homes that will only take people with mental health diagnoses, which has been kind of nice to help people step into maybe a group home or an apartment. And then you also have like assisted living facilities and family care homes for people who may have more medical issues, which usually comes along with this population. So let's talk about supports. We're all in favor of natural supports. The clergy, finding family members who may be willing to assist, friends and neighbors. Sometimes they have a significant other who's been waiting. A previous employer even might be available to help give them a job and give them a chance to do better. One of the most important things, and as a mental health professional, if you're a case manager, you will know is that it's really about that relationship that you build with the individual. A lot of people who are involved with the criminal justice system have these trust issues, and sometimes it takes a long time for them to trust someone. Being available to them and kind of being their quote-unquote person, building that rapport so that when they are ready to help themselves or get involved in the programs that they need to get involved in is probably the biggest takeaway I can give to you. I have a woman that has been camping out uptown in a tent for the last 6 years since I've known her when I moved into the jail system. And it wasn't but 2 weeks ago she had a crisis, and she called the police officer, who is like her person. He is actually her person. And she was ready to leave the street, and she has mental health issues, obviously. So he called in the troops. I mean, I took the SOAR application. We had a coordinated assessment person bring a laptop, and we met with her. We pooled all of our resources into one large meeting with her, and we all took a piece to help her get what she needed as quickly as possible. And so with that, I will leave this open for questions and answers.
All right. Thank you so much, Melissa. And we've had a number of questions rolling in, but we will feel free to continue to submit questions as we go through. We've got about 30 minutes to go through these questions. And while we are going through the questions, we are going to provide another opportunity for you to download the report. And also, this is available on the SAMHSA Store through SAMHSA's website if you would rather download it there. So just diving into the questions, and what we'll do is try to find the questions that all of our panelists can answer. But if there are specific questions that you would like to direct to one of the presenters, just let us know. All right, so I am going to just read through quickly to see which, I'm just going to start with this one question, and it is directed to George and Cara. And so regarding the use of telepsychiatry, this listener was asking, how do you manage the prescriptions around the medications for mental health and behavioral health needs as you provide services through telepsychiatry?
I don't think Cara heard the question real well. This is George. Ultimately, if it's we're using telepsychiatry, we have basically a bridge there at the medical clinic where we have a nurse that's available that's doing the vitals and basically doing all that, and then the scripts handle through.
Yeah, our providers, we have, like I said, the live family nurse practitioner for our medical or physical health scripts, and then we have the psychiatric nurse practitioner that does the psychiatric prescriptions. We have on-site pharmaceutical assistants. We actually don't dispense at the clinic. We dispense at our larger clinic, but we have the medication delivered to the north end so that they can leave with it in their hand, or we deliver it to their home. Depending on what the medication is and the acuity level, that really determines how often they're seen. But typically we're seeing they come for follow-up appointments every 30 days. Like I said, we have in the past done more bridging. We've really stopped bridging because we want to really teach people to keep those appointments. Initially, we had a really high no-show rate, but a lot of clients calling to get their medications bridged, and we really, what we've done is if they no-show, we really work with our probation partners and leverage that relationship, and they've been really effective in working with us to get the members in. Like I said, they'll issue a directive for them to come in. We get them in a standby. Even if they have to wait for a couple of hours, we try to get them in. And then hopefully with that, it teaches them the value in keeping a scheduled appointment so they can get it in and out a lot easier. So I hope I answered that question.
All right. Yes, thank you. All right, we've had someone else ask more specifically, and this will go to all of the panelists. When you're providing services, do you do anything differently for those individuals who present with intellectual or developmental disabilities or significant traumatic brain injury?
This is George Owens with Arizona Complete Health. We're on the beginning phases with the actually doing TBI assessments with the jail, and so we have a lady that works with our organization named Shanna Mays, and Shanna's been kind of spearheading us working with the jails and actually getting a basic assessment done with our jail liaisons. We actually have jail liaisons inside the jail. We know that there is a higher percentage of people being released from jail and prisons, about over 60% with some type of TBI. So we're at the early phases of that piece. As far as the assessment, we're pretty far along, but what to do next is where we're at the early phases on. And as far as intellectual developmental disabilities, I mean, that's something that we handle. We've had DDD, our Department of Developmental Disabilities, actually come and do some presentations with us specific to even crisis, and our crisis teams have been provided that. But we handle that on an individual basis, but we try to do a good job in recognizing it so that we can get to the actual people that could help us the most for that particular person.
This is Melissa This from Mecklenburg County in Charlotte, North Carolina. And to be honest, I have an affinity for the IDD population in particular. I've worked mostly with severe and persistent mentally ill and IDD, usually dually diagnosed. And I think it just kind of happened more serendipitously, but because I am a psychologist and I'm connected to a forensic evaluations unit, I have the ability and I have experience in testing because I have done a lot of psychological testing to either provide that testing, or my supervisor is a neuropsychologist and he can actually provide that testing as well. Because again, we have a lot of these individuals who don't have Medicaid, don't have their benefits yet, and sometimes we utilize that testing to help us in their SOAR application to obtain those benefits. Also, though, the prison system, at least here, and I believe in a couple of other states that I have had contact with, when I became SOAR trained, I accidentally got some prison records and noticed, well, I didn't accidentally get them, I asked for them, but I noticed that there was a printout of numbers. And I realized when I looked at it that it was psychological testing scores. And I was excited because I could interpret those. So I guess, you have to find out what works in your community. But I tend to put a lot more time and effort into someone who's TBI and IDD as opposed to someone who may be schizophrenic, is somewhat stabilized, and giving them some responsibility. I try to give the clients as much responsibility as possible for helping themselves. But ultimately, I think the screening for that is fantastic. I think that getting that kind of level of testing is going to be really, really important. I couldn't believe how many IDD individuals were in the jail when I moved in there about 6 years ago.
All right, thank you. We will just shift a little bit in topics because these questions really range across the spectrum. And so this question will go to Jenni, and as I believe this came up when you were talking about Principle 8 and community providers recognizing and addressing issues that contribute to disparities. And so one person commented, if you would have any advisement around the kind of training that people can participate in, or how to guide justice professionals around that, as they recognize that addressing cultural differences can go south sometimes.
Okay, and just to be clear, this is for training criminal justice professionals on how to interact with individuals with mental health and substance use disorders. Melissa, can you be, just a little bit more specific to make sure that I answer it correctly.
It said when training, the question isn't exactly clear, but it says something like when thinking about training justice professionals in recognizing cultural differences. There are some challenges in identifying cultural differences, and so how can you do that without conversations, quote unquote, going south?
Okay, thank you. Yeah, I would say there's lots of great resources now out there for correctional professionals on dealing with different populations that may be different, whether it be culturally, because race, ethnicity, sexual orientation. I know a lot of these are populations that are being seen in jails and prisons. And so the National Institute of Corrections does have materials on being culturally responsive and ensuring that interactions with different individuals and populations can, don't go south. I would ask if any of the other presenters have anything specifically that they are aware of that is appropriate training for culturally and linguistically appropriate care that might be able to be used in the justice field. And I'm happy to also follow up with that question with more information on that.
A couple of people have been asking about how to connect people with benefits when they've been suspended or terminated during incarceration. And so we've had a couple of people ask for guidance around how to start that process prior to release. And I do recognize this varies by state. So for all of our listeners to recognize that there are some state policies and laws that might be in place that will affect how you are able to sign people up for benefits prior to release. But if our two presenters could just speak to that as to how it works in your state, that would be helpful.
Hi, this is Cara. We are very fortunate in Arizona. We have a system called HIA Plus, which is Healthy Arizona Plus, and we have staff actually embedded in the jails that can do the input into the Healthy Arizona system to get everything filled out for their Medicaid benefits eligibility. The only thing they have to do at the time of the release is really activate it that the person's been released, and their benefits are pretty much reinstated very quickly. If we aren't able to get the HIA Plus application completed, what we do is we just have our system navigators or our case managers pick up the members from the jail and take them directly to our Department of Economic Security office. And it takes a lot of time and it's a lot of waiting that day, but we prioritize that and we make sure we get that completed so that we can, get in and get the bridges with the medication if needed and get them seen as soon as possible. But for the most part, the Healthy Arizona Plus system has been working really well for us.
And then this is George. That's for our population that is currently not on access or they fell off of access while they were in the jail. And as far as populations that's hitting the jail, that's on access, what happens is we have an automated system in Arizona where their access will be suspended, and then upon a release, there's uploads going between the county jails and the access department, our state Medicaid, and they'll suspend and unsuspend their access, so it works real well.
This is Melissa from North Carolina, and we have a little bit, ours was more fragmented, but in the 6 years that I've been like in the jail, moving from community mental health, I had to really learn to navigate. And I see a question from a program director at a jail about reinstating their Medicaid. One of the things I did when I came is I realized a lot of our individuals would just go down to the Social Security office and they say, we need your release papers from the jail. So we have a printout from our system in the jail. It's basically a historical summary. It has their picture and it has their release, when they were released. And I can sign that. Other people can sign that. We usually print our name or I put my business card with it. And our local Social Security office is aware of this. And so they take that piece of paper and they actually can reinstate their disability benefits because a lot of times their Medicaid is connected to that. And so that's one of the things we do. One of the other things I learned is that not all the state is the same. We weren't allowed to submit new disability applications for people in Mecklenburg County until after they were released from jail. And I just accepted that for a while until I heard someone in another city was able to do it 30 days before they were released from jail. And I said, well, how come they can do it, but we can't do that? You really have to ask good questions. And basically found out that there had to be an agreement between our local sheriff and our local Social Security office that we would be allowed to file those 30 days before release, which was just boggled my mind that's what it took to do it. So I just want to say that, sometimes you got to fish around and ask good questions to figure out how it best works in your state. But if you are working in a jail and can somehow streamline anybody who needs to go to Social Security for their check or SSI or SSDI can get some type of release papers, I'm pretty sure that almost every Social Security office requires some kind of notification, not just your physical body, but notification that you've been released.
All right. Thank you, Melissa. And we do have one specific question for George and Cara. So the listener was interested in the North End Community Center, and so they were interested in just getting some, maybe some brief kind of high-level information about how that was implemented, as they would like to introduce that concept to their probation department.
Great. Hi, this is Cara. North End Community Connections was developed as part of the Targeted Investment Program. So the state of Arizona received funds for specific initiatives related to health outcomes, and one of the areas of concentration was improving physical health for justice-involved individuals and really integrating physical and behavioral health for justice-involved individuals. So we had, access, a lot of support from Access, and we had some specific guidelines and core components that we had to follow as well that really assisted us in the beginning and really understanding how we were previously integrated and how we can improve our integration. So we really, the idea came from the Target Investment Program, and then what we really did, though, what really made it work was the leadership of the probation department, leadership with Arizona Complete Health, and leadership with my agency, Community Health Associates, really got together years ago and did so much pre-planning. And we were also, I think one of the biggest benefits that we've had with this clinic here is the space. We have target investment clinics in Casa Grande as well as Tucson, and the space we have found is really unique to Yuma County. We were really fortunate that there's space in the probation office to co-locate. Co-location truly is the key to the success of this. It's the intent of the program is to improve outcomes through co-location. So we were really fortunate to have the support of Arizona Complete Health and our probation partners, and we truly have everyone has a huge vested interest in the success of the clinic. We're all equal partners in this, and we could not have done this without the buy-in, not just the buy-in, but the, countless support we've gotten from the leadership at adult probation as well as Arizona Complete Health. I think the key has been establishing those strong relationships at the high level, and our commitment to working with each other, our commitment to working through some philosophical differences initially, and our commitment to making it work and us staying truly member focused. And we've created that culture, and it's spreading amongst our staff. So I think that's been the real key. A lot of pre-planning, a lot of anticipating barriers, and coming up with strategies to overcome them is what's made this product really unique. I can't speak enough about the collaboration and that same language approach. We have officers understanding so much more about treatment, and I have treatment staff understanding so much more about risk level and criminogenic needs, and we're truly getting our frontline staff on the same page and communicating well.
Great, thank you. All right, we've had a couple of questions come up about specific treatments or specific programs and how your work may overlap with these. So first of all, we had a couple of questions around medication-assisted treatment. And so one person was asking, how have you found the criminal justice system resistant to MAT being implemented as part of recovery? And the other person asked, well, we'll just start with that question. I'm missing the second one, but so we'll just start with that one. Have you found that the criminal justice system is open or resistant to having MAT available as part of that recovery process?
This is George Owens with Arizona Complete Health. I work with the whole state through Pima County, but our whole state's very receptive to medically assisted treatment, and even some of our detention facilities have the ability to do medically assisted treatment within actually when someone's detained. So we haven't had any resistance there. In some of our smaller counties, we're still trying to develop detention programs, so when people are detained that they aren't having to go through a withdrawal process if they're on like methadone. So we're working on improving things in Arizona. But as far as our justice partners, probation and the jail and even our specialty courts, they've been nothing but supportive of it, and actually been the ones pushing it a lot of times as far as we need to get this done. So they've been good partners.
And as a follow-up to that, what does that look like in terms of ensuring integrated care between receiving MAT while under criminal justice supervision and then ensuring that treatment continues once that person is no longer under criminal justice supervision? Can you speak to that piece?
Well, the one thing as far as our clinics and our services go is our services and clinics continue. We want them to successfully get off of probation or parole, but we don't want them to end with the clinic. We want the clinics there to support them and their family and their life. And if we want to move them to another clinic later, that's perfectly fine. But we're here for the long haul as far as that member. We have adult recovery team meetings and someone gets off probation or parole, then that probation officer or parole officer would exit out for that team because they have other cases to take care of. But we would keep going with that particular member.
Wonderful. Okay. And the other question was more specific. Oh, go ahead.
Oh, this is Jenni. I just wanted to say, in terms of that, in response to that first question about criminal justice partners, I just want to make sure that anyone who is on the phone that might be interested in this, the National Sheriff's Association and the National Commission for Correctional Health Care just released back in October the jail-based medication-assisted treatment, promising practices, guidelines, and resources for the field. And that has been very well received, and I would encourage anyone that's interested in seeing that and potentially working with their criminal justice partners, especially their sheriffs or jail administrators. I would say, the criminal justice, there are many criminal justice stakeholders who are really embracing MAT.
Thank you. That's a wonderful suggestion. That is a wonderful resource. So just time for a few more questions. One person asked if either of the three presenters that we're talking about, principles 5 and 6, 7, have any of you worked directly with the American Indians or Alaska Natives? And if so, can you speak to any, particular recommendations around working with that population?
This is George with Arizona Complete Health. As far as our agency, we actually have a tribal liaison that works with our agency that works specifically with the tribes. As far as our release plans, we actually I'm not well versed on it, but we actually have some tribes where we actually have jail liaisons as part of their detention facilities and doing release planning for those individuals. And as far as state parole as well, but that's being culturally sensitive and understanding what's going on and what their choices are is important. But we do have we try to make sure that we meet with our tribal partners and we meet with the tribal judges, and we do our very best on making sure that we're meeting their needs. As far as if they're on probation or parole, they'd get the same services, and then we would tie in their treatment people for that particular tribe. When we do release plannings, a lot of times we'll have the tribal release planning people there when we're working on cases.
And Melissa, this is Jenny. I would say also both SAMHSA and the Bureau of Justice Assistance do have quite a few resources for working with American Indian, Alaska Native, and tribal populations. So I would encourage people to go to both of the websites for those federal agencies and see what resources are out there.
Thank you. And related to another kind of treatment or approach connected with what you all are providing. So one of our listeners asked about assisted outpatient treatment and just asked, is this being utilized, and is this something that, individuals could potentially be released into, once they are released from a correctional facility? So would any of the presenters have anything to share around any work with assisted outpatient treatment programs in your communities?
Currently, Melissa is from North Carolina. We do not have an AOT, but we are trying to improve our outpatient commitment with our jail, our local police, and our hospitals. We have several different committees working towards improving that communication, because right now it's very fragmented. Our system is very fragmented. But we do not have AOT, but I've brought it up several times because I think it's something that we need to look at as a state.
George or Cara?
We're not as familiar with the language as far as AOT. I mean, so we're probably not well versed on answering that question. We do a lot of what in Arizona we call. I'm looking at it looks similar to what we call wrap services, which we do, but I'm definitely not going to try to say that we're doing it without knowing more about it.
Okay, no worries. All right, so I had a couple of people ask about funding, and so if all three presenters would just briefly comment on how your programs are funded, and whether that's a combination of funding sources or just one. So just give a high-level overview of how you're able to fund your programs.
Hi, this is Cara. So the North End Community Connections, that specific clinic, we did receive some startup funds essentially to get the construction done and get things up and running. The idea is that by the end of the third year that we're sustainable on our own. So we did receive some federal dollars for startup, but everything we do is all fee-for-service, billable services, and the idea is, like I said, we create a sustainable model long-term, and we're able to sustain on our own after year 3.
This is Melissa in North Carolina. We have a jail diversion is what I'm part of currently. This position that I'm in has been around since 2001, but it was utilized differently when we had county community mental health. They privatized our system, and so I moved into this position because I knew it would change. And I think because we are county funded, we don't actually bill for services. So it gives a lot of latitude in terms of what we can do because we are really filling gaps for some of our consumers. We were able to get a second position because it proved to be quite successful in getting people their benefits and then getting them housed or getting them into the programs because they are so, the ones that we particularly deal with in our jail diversion, we're diverting people even on the street before they even get to jail at Intercept Zero because they are difficult and they need multiple agencies and collaborative efforts involved. And so I think that as time goes on, our area will probably grow and with licensed clinicians who can do multiple things to help them get into the regular mental health system.
Great, thank you. And I think for our last question, so we've had a couple people ask about the involvement of peer support services. So would the presenters, all of you, comment on, how peer support is utilized in your programs, or how you try to incorporate it in the services you provide?
Hi, this is Cara. We definitely incorporate peer support services into almost all of our clinical activities at the clinic. Peer support from the beginning, they engage with the clients while they're still detained to go ahead and start building that relationship. If they are not detained and they're coming in from community supervision at the time of intake, we have a peer support. Like I said, they're co-located, they're on site with us, so we don't have to refer them out to us. It's a different agency, but it isn't a different building, so they're right there. I don't think our clients can even really tell the difference between agencies because we all work so closely together. And during the intake, we always get a peer support, or we try, depending on availability, to have a peer support jump in the intake to at least sort of explain and pitch their services and let them know what the value in peer support services is and what they can do for them. So we definitely know the value of it. We use our peer support services. They facilitate a lot of our evidence-based group programming. They assist with having the discussions on physical health. We have a lot of peer supports that, credibility goes a really long way when helping a member make a decision on whether or not they're open to attending a physical health appointment. It can be very anxiety-provoking for some of these people that haven't seen a medical provider for a really long time, and the peer support really is the key, the critical component that kind of helps them get through that process. They facilitate, MRT, relapse prevention, a variety of different groups for us, and we work so closely together. We jump in our treatment team meetings together. We're staffing cases constantly, and we're true equal partners with our peer support providers at the clinic.
And this is Melissa. This in North Carolina. I love peer support. We have a clubhouse actually that is nationally recognized in Charlotte. We got very lucky with that. Our county actually funds peer support through that agency for people who don't have Medicaid. Because as you know, if they have Medicaid, that we have multiple agencies actually who have peer support if you have Medicaid. So most of our people do not. So we also have several that sit with our treatment courts that are involved specifically with the treatment court population. And we actually had a fledgling peer bridger kind of thing with the jail for a little while with a provider. We had some bumps in the road, but we are trying again, hopefully soon with another provider to try to work through some of those issues because it really makes a difference to have another person in their corner, someone that they can talk with. And I can't talk enough about the value of peer support.
All right, thank you so much. All right, so that brings us to the end of this webinar. If you would like to get the slides and a link to the recording once it's posted, please do sign up for our listserv, and we will be sending out that information and those materials as soon as they're ready via our monthly newsletter. And you can see a link here should lead you to a web page where you can sign up for our newsletter. And also, if you have any other questions or would like to reach out to us directly, one way to do that is to reach out to the Substance Abuse and Mental Health Services Administration, and I have their contact information here. Or you also could reach out directly to us here at the Gaines Center, and we are happy to follow up with you with any questions. One of our roles is to provide phone-based technical assistance to people across the country, so please don't hesitate to reach out to us if you have any questions that we can help you with. And with that, we bring this webinar to a close. Thank you so much for joining us today, and a huge thank you to our panelists for providing this really critical information. We really appreciate your time and investment in sharing this information with the field. All right, thanks everyone. Goodbye.